many countries have gone far ahead doing these things, but we are where we are now. So it's never too late. So now that we are starting, so we want to see how many people will be recruited into this and then we'll be able to be able to gain level of capacity that can respond to questions in the public health space. And we are really needed. We are really, really, really needed. Today, what we are doing again, we'll see much more. Continuing from where we stopped yesterday, we will be having Prof to take us through the first session of the day, a real world example of malaria modeling, hoping to see Prof was telling us of what modeling can do, what we can to achieve. Have we done it before? Yes, we have done it. We are doing it, and we still continue to do it. So we would like you to see some of the things, beautiful things that we've come up with. So Prof, taking process, through this kind of thing. So please, I want us to get prepared. Let's open our hearts and then be ready to absorb as much as possible. Ask questions when it's not clear. You don't need to wait at the end of the session. You can raise your hand in case you clear something in the course of the training. All right, please join me again to welcome Prof this morning as the opens the floor for us. Welcome class. From the overview of malaria mobility option is in general. And we talked about the modeling process. After the price, policy questions, and then from there to data conceptualization. Look at various kind of data, the kind of question I would actually use for the kind of question do not really do. So I want to this point, I told you yesterday, the kind of factor example what has been done before. One of them, not all. Now, there was this paper on the modeling of the effects of non-lasting external on malaria and federal and its was always here in like Syria, infection disease, nobody, volume 11, 2006. So, I will just give a kind of a weekend recap on discussion on the future. Now, the background information on this paper, if you type online, you see this paper and download it to your chat. Now, you all know that Nigeria is the highest body conflict world, roughly 27% of global malaria cases. And within Nigeria, people say the highest prevalence sitting at between 49 and 52% via microscopy evaluation. So, and then malaria transmission in KBC is high endemic, heavily driven by signal elements, tracking uniform spikes, optimal ability during the wet season. And then while NNI have been actively deployed across the states, its structural gap persists between ownership and consistent usage. The baseline operational usage, operational net usage within communities was recorded at just 13.2%, very standard information and effective. Now, what's the aim? The aim is to study, is to, for these studies to assess the effect of malaria transmission dynamic in KG states, Nigeria. The flash question is what an effect of the NNI malaria transmission dynamics in KG states, Nigeria. And then our objective is to determine the effects of NNI on malaria transmission dynamics in KG states. So, the materials and methods to use routine data to confirm complicated cases in KG states in Nigeria from 2015 to 2024 to understand the transmission dynamics within the population. The deterministic of African model was developed and to capture malaria transmission dynamics in KG states. And then we carried out some quantitative analysis using established techniques. When disease pre-epidemic was analyzed and all these other stuff were done, effective production number was also done. Now, the study area of the steady state is in the northwest. Nigeria lies between Zamfara and Niger State in the south, and between Sokoto to the west. So the total land area of any state is around 6,000 square kilometers. And then there are two primary seasons in the states, the rainy season, which is May and October, which was which have the highest rainfall from July to September, and dry season, which is characterized by decreased heat and dry heat temperatures, particularly between often the warmest months. And then the description of data we have, the data is ranges from January 2015 to 2024 May. It was obtained from NPR platform, and then the data was are not publicly accessible due to governmental policies to maintain confidentiality requirements. And then the assets can be granted the conference following necessary approvals. Variable set of data comprises of 113 observations and includes confirmed or contested malaria, persons clinically diagnosed malaria, children under 5 years, who receive NLI, persons with confirmed or contested malaria with ACT, persons clinically diagnosed malaria to with ACT. And then okay, also on that, we have the confirmed complicated malaria cases data for kidney stage to understand the transmission dynamics of malaria within the population. So these uncomplicated cases are confirmed through the use of microscopy or RDT for all age groups, who sought care from reporting health activity. So we also obtained the time slot for this, which is here. You can see the time slot, or it's actually seasonal. You see the seasonality there, and then it's taken from 2015 to 2024. And we also develop, development of model development projects, the model development. So we develop a dynamic model that incorporates the effect of LLI and mean the dangerous mixed population. Now, this is the facts in my the cycle continue again when the infected mosquito also bites the human, the synthetic human. I mean, so it's a continuous cycle like that. And then they also die naturally, new edge, and then people, I mean, infected and exposed infection mosquito also increase from their infection plant to infected plant, infectious plants. And this is another age identified. Now, this section presents the to calibration. Now, I said something yesterday that now after project under development, we also have project calibration or what I call model fitting and parameter estimation. Now, that's when you bring it on back, like maybe like X-ray method or you bring maximum like those are frequent, those are post and then which one we have engaged X-ray method to estimate some of your own parameters in the model. And then there is also what we call the variation. That variation approach is FPLC. That's the backup chain simulation. So, but this section, Kevin says monthly malaria cases from 2015 to 2024 were used to calibrate model 10 using the method of square estimate with our software. So the method seeks to find the model parameter that values that minimize the sum of square errors between the model and the data. That is where the yi is the number of malaria cases and the I month and the y x that is the estimated malaria cases and the I month, which depends on the model state variable x and parameter class. So the initial condition for malaria model then are obtained as follows. The symptomatic infectious human population respecting to the number of cases in January 2015. Hence, stage of 0 is equal to 17, like 177. And then we assume that the exposed amount of people which is infectious is equal to pH of 0 equal to 0, and the symptomatic infection population is assumed to be 5 times as much as RH of 0. That is AH, which is a asymptomatic infectious humans. They are 5 times 177, so it's stated 5. Now, the total population of every state in 2015 was 4 million plus, so that the initial total of human population is 6 years. So it follows that the initial susceptible population is obtained given this. And then the numerical simulation were performed using the estimated parameters obtained from the model calibration described in previous section, together with fixed parameter values listed in 23. Now, the initial conditions were defined to represent all age population of any state, thereby enabling simulation of the disease dynamics for the entire population. So we also carried out local specific analysis to determine the parameter that influence the effective production number hosts, and then the duration of the effective production number and the malaria prevalence with respect to the identifying parameter were assessed using maps. This visualization enables the systematic assessment of how changes in parameters influence malaria dynamics. Now, these are measures of uncertainties. Yeah, so the calibrated ballistic model was sought numerically to generate monthly malaria system trajectory under alternative LLI use scenarios. Simulations were performed over 2 time horizon. First, a retrospective simulation covering the 10 observation period. That's yesterday I was saying that in developing in the course of carrying out your scenario analysis, there are 2 parts of it. You have retrospective and retrospective. And the retrospective is to look at the impact evaluation and what you can learn from the past events. So you carried out that there and was evaluated to evaluate the counterfactual effects of building NNIN on malaria and dynamics. Now, this retrospective analysis quantify the magnitude of malaria cases that could have been averted relative to the baseline use of 38.2%, which corresponds to an estimated NNIN protective effectiveness of 1 equals to 0.34. Now, alternative scenarios have shown increase NLI use of 50% and 80% corresponding to a protective effectiveness values of V1 equals to 0.45 and V1 equals to 0.72, respectively. Now, these scenarios are based on the assumption that the protective effectiveness remain constant throughout the study period. Not, but it's a starting point to check what's been done. Now, second simulation of future monthly malaria incidents were conducted under the 50% and 80% airline scenario to assess their potential long-term influence of malaria in Kebbi State. And then this protective simulation assumes that other intervention components and demographic parameters remain constant, thereby isolating the effect of increased LLI use. And then, from a policy perspective, the 50% LLI use scenario reflects a moderate but realistic rate, achievable through sustained routine solution and informative engagement. And then, while the 80% scenario represents aspirational but programmatic relevant targets aligned with specified mass campaign and improved net intention and efficiency. And together, these scenarios provide quantitative evidence to inform LNI scale-up strategies and highlight the potential public health gains from translating LNI ownership to consistent and effective use across communities in place. Now we have the parameters, the values for the malaria transmission, those that are fitted and those that receive from fits were taken from literature. And the result of fitting the nutrient duration with the actual state malaria incident displayed in blood. While 23 gives the summary of the model parameter values obtained from the fitting process. Then the index of agreement IOA is 0.9308, which implies a strong degree of agreement between model and data. That's like 93%. Now, and then we have the fitting here, then we fitted the model with data, and then showing monthly observed malaria cases. The red happens to be the model, the blue dot happens to be the data. So compare with the model-based outputs from model 10, and then illustrating the model's ability to capture the temporal dynamics of malaria incidents. Now, a global sensitive analysis identifies which parameter exert the most profound influence of changing RE with overall pace trends. The vector baseline biting rates has a positive correlation index. Higher biting rates significantly accelerate transmission velocity. Negative drivers, the natural mosquito mortality rates, mu(n) has a powerful inverse relationship. Small increases in mosquito death rates dramatically crash the vector population capacity to complete the extraction cycle. Then the control wave, the LLI demonstrate a strong direct negative sensitivity index, mathematically validating nitrogen as the most valuable leverage point for public health suppression campaigns. So the paper runs a retrospective and actual simulation from 2015 to 2024 to measure the impact of past policy shortfalls. Now, it's very what if Kebbi State has successfully scaled and sustained LLI to 80%, starting back in 2015, instead of leaving it open at 38.2% baseline, reaching the 80% usage threshold historically would have given 97.9% reduction in transmission levels. Public health abated. The simulation proves that 5.2 million clinical malaria cases would have been entirely prevented over that 10-year period, saving thousands of lives and drastically relieving economic pressure on the state healthcare system. Now, the final phase of the paper maps predictive outcomes of Kebbi State from June 2024 to December 2030 across the intervention. Now, Maintaining status quo, that is business as usual, 13.2% usage. Malaria will remain highly endemic, experiencing signal explosive spikes, draining state resources, and preserving Kebbi's position as a hyper-endemic hub. And then scaling to 50% usage results in a moderate 37.9% reduction in physical incidence, but far short of emigration goals. Scaling to the 80% critical threshold, the projection indicates that an immediate deceleration in transmission and driving 78.9% overall reduction in statewide malaria incidence by 2029. This trajectory effectively about 2.9 to 3 billion future clinical malaria cases and puts KB on a track for pre-elimination phase status by 2030 in the presence of other interventions, not only LNI. Now, we have the prospective assessment of the effect of LNI and gas scenario from 2024 to 2030. So that's a kind of picture. Now, and then the core recommendation for policy makers shift focus from distribution to usage. That is, moving the target metrics of the state malaria elimination program from net ownership by distribution numbers to confirm consistent 19 usage. Now, and then behavioral change of obligation. Now, implementing intense, localized community sensitization to overcome structural patterns of net misuse, e.g., net use for farming or storage away. And then resistance and efficacy trade tracking, pairing expanded net distribution with entomological monitoring to track mosquito insecticide resistance and physical net degradation over time. The limitation of the work, one is homogeneity of the population architecture. We have assumed that everything is homogeneous in terms of the underlying OD assume a homogeneous population. We treat all over us as having technical risk profile, vector contact rates, and economic time rights. The impact in reality, malaria exposure is highly heterogeneous. The model cannot capture age-dependent immunity sheets, e.g., how clinical body transitions from under 5 to school-age demographics, as functional intensity changes, or spatial clustering in specific local government areas of every state. Now, number 2, limitation, absence of explicit asymptomatic calibration methods. Like, although the model structure carefully separates IH and asymptomatic and asymptomatic compartment, the historical calibration relies entirely on the NFDR, that is that's a National Malaria Data Initiative, tracks clinical health facility based record. The impact, because asymptomatic individuals hospital care. So the AH compartment is fantastically required rather than directly fitted to active community biomarker surveys such as PHS or malaria indicator survey. And then this might lead to an underestimation of the true underlying parasite reservoir. The simplistic, the third one, simplistic representation of vector mechanics. While seasonal causing parameters are applied to vector vitamins to capture rainy season, the vector lifespan, mortality rates, and exclusive incubation period are treated as static constants. And then the impacts, climate variables like micro temperature variations and humidity fluctuation profoundly alter how fast a mosquito matures and dies. So treating this parameter as static dampens the model's sensitivity to extreme climate anomalies like chaos or prolonged drought in northern region of Nigeria. Then the fourth limitation is that behavioral statistic in LNI injection. The predictive scenario, scaling up to 50% or 80% net usage, assumes that usage rates remain perfectly constant and uniform once achieved over the 2024 to 2030 timeline. The impact, it does not account for the structural decay of deaths over time, like physical washing out of insecticide or behavioral fatigue. You know, because the net is or has other properties, you know, in terms of apart from the killing rates, it can also when the mosquito lands on it, it can kill the mosquito, and then it can also have not allow the mosquito to penetrate inside where the human being is. So or be a general fatigue where communities revert to low usage during dry season. I think that somebody was about that when when they high temperature, people don't withdraw from breathing nets, you know. So and then future work, transition to age structure and specially SPT model. The path forward expanding the statistical framework into age 35 month better population model. What's the benefit? This will allow researchers to explicitly capture how acquired immunity shield adults compared to infants. Now, and map specific transmission corridors between different border zones of Kebbi State and neighboring regions like Niger Republic that share border with the Kebbi State or Benin Republic. And then number two, integration of cross validation. You know, I said the other time that before you general analysis, you are supposed to carry out validation because that's going to prove that your model is a true of what we at least what data at least have percent data. So but we have not carried out there. Yeah. So these are part of the things you can still do. So calibrate the model balance against both hospital records and community level biomarker data set like DHS, MIS, using a technical scale parameter after. And then the benefit is that incorporating validation methodologies such as also task force validation we rigorously strengthen the model capability across all subject practical clusters of years. Now, private difference to passive parameterization, their future work, pathway is that upgrade the deterministic system writing function to a stochastic differential equation directly driven by real-time satellite data inputs for temperature, precipitation, and vegetation indices or even humidity. The benefit, this dynamically updates mortality, that is mosquito mortality, and the parasite development rate within the vector, enabling the model to serve as an early warning for system for climate-induced malaria resurgences. Now, coupling with health economics and optimization engines. Now, the path forward is integrate a formal cost-effective analysis pipeline into the projection engine to calculate the ICR for scaling NNIN versus deploying alternative vector tools like IRS or SMC. Benefit. This could deliver output from theoretical technology to actionable financial frameworks, providing ABC policy data with exact budgetary mandate, showing the cost that is averted. So these are some of the references. And then, thank you very much.
Explain that very intensely. And I want to believe that, like Prof said, the paper was just to demonstrate, and this is starting from, like he said, of how to build a policy relevant model work, which Prof has seriously demonstrated if we actually follow the work. And then indicating sometimes in places where there is need for improvement, which those improvements are already being incorporated by ongoing works that people are doing. But at least for the first step, we see what we have been able to come out with one of the papers that has been published among many other ones. So now on using mechanistic model that the majority of us are familiar with, which normally in the mathematics balance, what we do will just be more of theoretical something, not bringing it to any place. But now that same mathematics is now being used to confront data when we are talking policy and policy recommendations. I think that's a very important, good one for us. And then how to please engage this, ask questions, particularly based on what has been presented, and maybe there are other things that are not so clear you want to clarify. Because after now, we are going to really go into it, how to come up with model and all of those things, which is the next one. But let's engage this one that has been done already. If you have questions, guys, see you around. You can indicate. Are people already online? Good. So if you have online participants also who have questions, we can also let us know. And there are questions for from what the top has shown us this morning. We can check the paper online. It's reached by IBM, Effectual Modeling. So you can check it and read it. Okay, it seems people don't want to ask questions. Thank you. Let's just start from. Okay, so we want to have a session on developing a simple. Okay, thank you for time up.
Mr. Seriously. Starszy Maciej, no, wyróżniający. Was it's the news.
And you quickly go back to it. On for the class. Okay, it's 11 already. So let's look at our this rate in the next 15 minutes. And we'll return to have to continue the lecture. So the 15 minutes start now. Let's go for the break. Thank you. It's tea break time. Let's go for tea break. 15 minutes, please. Please help me check the time. 11 what? Okay, so the next 15 minutes will be by 11:15 we are returning for the next lecture. Thank you.